All right, so the focus for today is going to be on AFib, and to kind of get us introduced to it, I'm going to start by how does the heart normally work, and then what goes wrong, and how do we get AFib, and how does it show itself. We're going to talk about associated conditions with AFib and spend some time focusing on the associated stroke risk, because that's one of the big complicating factors. We'll talk about treatment options, both for reducing that stroke risk and also treating the AFib itself, and what can we do to help patients who have it feel better and get their quality of life back. So starting with the normal stuff. So how does the heart work and what's the normal structure of the heart? The first thing that comes to mind when you think about the heart is that it's a pump, and the blood kind of flows through the heart and is circulated throughout the body. The heart has 4 chambers, and the 2 on the top are called the atria. So we have a right atrium and a left atrium. And the 2 on the bottom are called the ventricles, and we have a right ventricle and a left. The blood returning to the right side of the heart goes from the right atrium through this valve here to the right ventricle, and then it's sent up to the lungs. And this is where it gets oxygenated. And then it returns through veins that bring it from the lungs back to the heart. But this time it returns to the left atrium. And it goes through this other valve called the mitral valve into the left ventricle, which is the main pumping chamber in the heart. And this is the one that squeezes it out and circulates it through the aorta and through the rest of the body. So just by size, the atria are thinner and smaller compared to the ventricles, which are bigger and more muscular. The reason why they're more muscular is because they have to carry the heavier workload, but the atria also have an important part to play. So this cartoon kind of illustrates that blood flow that I was explaining, but it also has on top of it the electrical component. So the example that I like to use here is, if you think of a car and you have an engine that is burning fuel and squeezing and getting the wheels in motion, every engine needs a spark plug. So you do need that electrical spark to initiate that contraction and move those pistons. So as you can see, every heartbeat here in the cycle on this cartoon starts with a spark. And our hearts are born with this native electrical activity. So the heart is one of 2 organs in the body that actually generates its own electrical signals, the other organ being the brain. So it's a highly regulated system, and the beats come from the normal spot. After the electrical spark comes the contraction. The blood moves across these chambers and through these valves and gets out of the heart in this very organized fashion. And when we do a recording of that electrical activity, when we do the electrocardiograms or EKGs, on a normal person in a normal rhythm who's sitting at rest, you'll notice that every spike of the EKG corresponds to a heartbeat, and it's a regular pattern, and it's not terribly fast when we're at rest. It can go slow, and that's normal when we're resting or sleeping, and it can go faster with activity like exercise or emotional stress. So these are all normal behaviors of the heart, and the heart responds to other stimuli from the body through the nervous system. So that's how it can regulate its heart rate up and down depending on the body's needs. Now, one of the common disorders that affects this electrical activation of the heart is our subject for today, which is atrial fibrillation. So what happens with atrial fibrillation is, instead of the highly regulated, very organized way of stimulating the heart electrically, and subsequently the highly regular beating pattern, we replace that when we have AFib with a highly disorganized and usually fast rhythm. So the characteristic of atrial fibrillation, which is an electrical disorder that causes the upper chambers of the heart to beat fast and irregular. As you can see in the cartoon, we have multiple arrows pointing in different directions rather than a very smooth activation like you saw in the cartoon previously. So when you have all sorts of electrical waves going in different directions in these upper chambers or the atria, the end result is a highly chaotic and usually fast pattern of activation of the heart. So when you record the ECG in somebody with atrial fibrillation, you can immediately notice that the beats are closer together on average compared to the one that I showed you before. And then also, if you try to measure the timing between beats, it's really chaotic. So there's no rhyme or reason to it. And if you're trying to feel a pulse in somebody with atrial fibrillation, you also notice the same thing, that the pulse is very irregular. And it's like an offbeat drummer, where every beat comes at its own timing and there's no pattern to it. Now, this is a very common condition. And right now, the estimated number of patients who have atrial fibrillation in the United States is about 5 million. And as we go forward in time, the estimation is for more and more people to be diagnosed and to continue living with atrial fibrillation. So as we do a good job helping people live longer with chronic health conditions, especially cardiovascular problems, and with new people getting diagnosed with atrial fibrillation, there's going to be an accumulation of the number of patients who have this condition. So the estimates for 2050, for example, which is 30 years from now roughly, is for the number of patients with atrial fibrillation to go up to about 12 million. So something that is already very prevalent, and it's expected to be even more prevalent going forward. Now, it is also a condition that becomes more prevalent as we get older. So as our population gets older in the United States, we also expect to have to deal with AFib as a common condition as we go forward. Now, the pattern of AFib is an important thing to talk about. As people start getting diagnosed with it, they usually have brief episodes. So they have an episode of atrial fibrillation where they feel the symptoms, and when we record the ECG, we diagnose it. They have it for a short period of time, and then it stops. They go back to normal rhythm after that. So this sort of starting and stopping pattern is called paroxysmal AFib. And that's usually where most people start when they get diagnosed with atrial fibrillation. Occasionally, you can go into atrial fibrillation and get stuck there. So it doesn't stop on its own. And when it lasts for more than a week, continuously where you're in atrial fibrillation, this is what we call persistent atrial fibrillation. So most people start with paroxysmal and go to persistent if they're not treated, but some go to persistent right away. And you have to do an intervention to get them out of atrial fibrillation and back to normal rhythm. And we'll talk about what different interventions are in a little bit. Also, if you leave that untreated and you allow the AFib to kind of continue to progress in its natural course, it goes to another phase called permanent AFib. And this is when you basically can't get rid of it anymore. So despite all of the treatment options that you might try, it finds a way of coming back, and you just basically can't get rid of it, and patients are in it all the time. So that's kind of the end stage of the progression of atrial fibrillation, is to get to that permanent form. Now, what are typical symptoms that we encounter when we're treating patients with atrial fibrillation? I'd say the most common thing is shortness of breath. That shortness of breath can be at rest, but it can also be with activity. Most patients feel it more when they're doing more physical activity, like walking or going up the stairs or doing any kind of exercise. Another group of patients will also experience a racing in their heart. They feel like there's a rapid pulse, or they can feel that their heart is beating fast in their chest. Some describe also another chest feeling of fluttering or butterflies, or a horse that's racing inside the chest. And there's a term that you'll often see called palpitations, and the word palpitations is a descriptive term that basically means that you're aware of something off with your heartbeat. So it can be a single skip beat, or it could be any of these racing or fluttering or horses running in your chest. So this awareness of the heart rhythm being irregular or fast or different is called palpitations. And it's a common symptom of atrial fibrillation. Other symptoms of AFib can be dizziness or lightheadedness. So some people can feel unsteady or woozy, like their balance is not the same. And it can also be something even more insidious, and people just feel more tired and they don't have the energy, generally fatigued, and they're not really feeling like they want to go out and do the same things they're used to doing prior to the AFib coming on board. And there's yet still another group of patients who don't feel anything at all. And this is usually more elderly patients. So we're talking about someone probably in their 80s or 90s and not very active. So all of these symptoms that require activity, where you actually need the heart to be responsive and to do the pumping work in a normal fashion and responds to the level of exertion, they don't really miss that because their lifestyle is limited already. So they can't really tell. And if they don't feel the palpitations, then they could be an AFib and not realize it. So why does AFib matter? It matters for several reasons. As I was just explaining, because of all of these symptoms, there's a clear impact on the quality of life. So patients who have atrial fibrillation come to us because they don't feel well. It's that feeling of palpitations, or that feeling of tiredness or fatigue or inability to exercise, or dizziness, or things of that nature. So clear impact on their day-to-day activities and their overall quality of life. And that's what we aim to improve when we're dealing with atrial fibrillation. But it's also important to keep in mind that there are associated conditions that are also super important to pay attention to and be mindful of, because we want to prevent them from happening. So those two conditions are blood clots and stroke that can result from atrial fibrillation. So this irregular rapid pattern of activation of the heart can lead to the blood clotting inside of that left atrium. And blood clots in the heart are bad news, because when they form in the heart, they can then dislodge and go places they shouldn't, like the brain, and cause a stroke that way. So we need to be mindful of that, and we'll talk about managing that aspect of AFib. The other thing that could happen is a weakening in the heart's contractility. So sometimes AFib can weaken that ventricular muscle. So the pumping is reduced, and therefore patients can experience heart failure as a consequence of atrial fibrillation. So that's another very important associated condition with AFib that we have to pay attention to and prevent or treat if we happen to diagnose it together with atrial fibrillation. Now, what causes atrial fibrillation? I mentioned to you earlier that there is a strong association between atrial fibrillation and age. So as we grow older, the prevalence of atrial fibrillation increases. So it is something that is more prevalent as we get older. It's associated with age, and you can think of it as yet another wear and tear thing that affects the body with advancing age. So wear and tear affects many organs like your joints or your muscles or your kidneys, and it can also affect your heart. So one of the ways it can show itself on the heart is with this arrhythmia, and that's the association with age. AFib also can run in the family, so there's a genetic component to it and some genetic factors. In fact, if you have a sibling or a parent with atrial fibrillation, so a first-degree relative, then the chances of you developing it are 4 times higher than someone else who doesn't have that history in their family. So there's a clear genetic predisposition if you happen to have that family history. There are other things that also are associated with atrial fibrillation. Some of them are cardiovascular conditions like heart attacks and valve problems and congestive heart failure. Other conditions like hypertension are also associated with atrial fibrillation. Sleep apnea and obesity are also associated with atrial fibrillation. Some lifestyle practices are also associated with it, like excessive alcohol consumption, smoking, and drinking. Caffeine. And then overdoing it on sport. So this is not by any means the majority of AFib patients, but there is a slightly increased risk of AFib in highly trained athletes. And I'm talking here about marathon runners or very long distance bikers. So I'm not discouraging anybody from exercising, but overdoing it on the exercise sometimes can also be associated with AFib. Now, what do we think of when we're managing atrial fibrillation? What are the goals of treatment? Like I mentioned before, we want to think about right up front that risk of stroke and think about mitigating factors. How do we lower the risk of stroke? And then we also want to think about how to manage the AFib itself. And if we need to get rid of it, what are our options? If there's any associated weakening of the heart muscle, what are our options there to help get rid of the arrhythmia and reverse and return things back to normal? So let's start with the associated stroke risk and what are the mitigating factors there. So it turns out that this association with stroke is very common, and it's something that our colleagues in neurology actually have to deal with not infrequently. So patients with atrial fibrillation are, on average, if you take the entire cohort of patients with atrial fib, their chances of having a stroke are about 5 times higher compared to patients without this diagnosis. So it is a big deal, and that's the reason why I'm starting with it, because it's one of the first things that we have to address when we diagnose atrial fibrillation. So how does this work? Like I mentioned before, when your heart's fibrillating and those upper chambers are having the arrhythmia and they're not really squeezing, they're quivering, that's a recipe for the blood to be more stagnant, and stagnant blood tends to coagulate. So on the black and white image here that you see on the right-hand side, this is an ultrasound image of the heart done through an ultrasound that goes down the throat and gets closer to the heart and takes very detailed pictures. But you can see that there is a blood clot right there, that circular thing that the white arrow is pointing to and my mouse is pointing to. So those blood clots tend to form in a recess in that left atrium called the left atrial appendage. And because it's a recess and it's not part of the mainstream of the circulation, it's prone for the stagnation and for the blood to clot over there. So stagnant blood turns into a clot. A piece of that clot or the entire clot will get dislodged, and it goes into the main circulation, and it goes downstream. And if it finds a vessel downstream that's just too small for it to keep going, it will stop there, but it will occlude that vessel. And if it happens that this vessel is one that's going up to the brain, then that part of the brain that's fed by this vessel will then suffer because it will stop getting any blood flow. And this is how strokes happen when you have atrial fibrillation. So this is sort of how it happens. And again, going back to how it looks from the neurology side of things, actually 1 in 5 strokes that are diagnosed in the US are attributable to atrial fibrillation. So it accounts for a significant proportion of ischemic strokes that are diagnosed. And as I mentioned before, those blood clots that we worry about happening in the heart when you have atrial fibrillation, 90% of the time we find them in this recess called the left atrial appendage because of its anatomical shape and because it is a little bit secluded from the main circulation. When you do have a stroke that's related to atrial fibrillation, there's another hit here, which is that those strokes that are related to AFib tend to be even worse than strokes that are due to other causes that are not atrial fibrillation. So they're much more likely to be disabling, and they're much more likely to be fatal. So it's not that there's a high chance of stroke, it's a high chance of a bad stroke. So how do we reduce the risk of stroke? We first have to look at several risk factors on the clinical side. We look at age, we look at other associated conditions like diabetes and high blood pressure, and a previous history of stroke, and congestive heart failure, prior heart attacks. All of those things actually factor in the way we assess every individual's stroke risk. And for people who are deemed at increased risk of stroke, the way to reduce that stroke risk is by thinning the blood as one of the main options. So if you give someone a blood thinner, then what you're doing is you're making it much less likely for that blood to clot or coagulate in that left atrial appendage. So you reduce stroke risk in patients with atrial fib by using blood thinners by about 2/3. So blood thinners don't completely eliminate the risk, but they significantly reduce the risk. Other options that are not medication-based to reduce stroke risk are procedural, and they're aimed exactly at that recess that we've been talking about, the left atrial appendage. So there's a couple of options that we have that are catheter-based, where we can occlude that left atrial appendage. So we isolate it from the circulation so that any blood clots that can form there will not be able to get out and go downstream and cause a stroke. So these left atrial appendage closure devices that are showing here are used as an alternative to blood thinners for patients that are either not good candidates to take a blood thinner or just prefer not to take a blood thinner. So we do have some alternatives, but either one of the two options, whether it's a blood thinner pill or a left atrial appendage occluder, is something that we have to think about in people who are deemed at high risk for a stroke. Now, what are some of the common blood thinners that are out there? Warfarin or Coumadin used to be our most commonly used blood thinner. It's been replaced by some newer drugs. Warfarin or Coumadin is still used for some patients who, for example, have artificial heart valves or have bad kidney function or have reasons that they can't be on the new blood thinners. But in this day and age, if you are a newly diagnosed atrial fibrillation patient and you're going to go on a blood thinner, you're more likely to end up with one of these newer agents like Eliquis or Pradaxa or Xarelto or Saveza, more likely to end up with one of these four compared to going on Coumadin, because Coumadin requires blood draws to make sure the blood thinner level is not too high or not too low. And it's also affected a lot by what other medications you take and what food you eat. So for that reason, the Coumadin option requires a lot of monitoring, whereas the other options don't require that much monitoring. So most people take these blood thinners and have very little side effects from them. But just like with anything, you have to balance risk and benefit. So the benefit of blood thinners in the case of AFib is reducing stroke. But the risk of blood thinners is that it puts the patient at risk for bleeding, because now the blood is thin and it's not going to coagulate like it normally does. So when you're thinking about prescribing a blood thinner to an AFib patient, we are always trying to balance the prevention of stroke, the risk of stroke and its prevention, balance that against the risk of bleeding, and going with either a blood thinner or thinking about alternatives like those devices that I showed you. So that was what I had to say about stroke associated with atrial fibrillation and assessing that and what treatment options we have there. I'll move on and talk about what options do we have to manage the atrial arrhythmia itself. How do we treat the irregular heart beating, and how do we manage the symptoms, and what options do we have there? So we have several options, luckily. Everyone who is diagnosed with atrial fibrillation needs their heart rate to be controlled. So we don't like patients to have a racing heart all the time. This is one of the things that can lead to the heart muscle weakening. So we don't want our patients to have a fast heart rate all the time. And rate control means using medications that slow down the heart. So we don't want it to race, and these medications help us bring that heart rate down. They may not get them out of the arrhythmia, but they will definitely slow them down. And this way we can start exploring the other options to get them out of arrhythmia without worrying that they're racing all the time and that their heart's going to get weaker and weaker. So that's what rate control refers to. Rhythm control, on the other hand, is when you're actually trying to fix the rhythm. So we are now thinking about, okay, what are our options to get rid of this AFib and bring back the normal rhythm, the normal way that the heart is supposed to work. And for that, we have also some medications that are referred to as antiarrhythmic medications or antiarrhythmic drugs that would chemically try to bring the heart out of atrial fibrillation and back to normal and try to keep it there. And then we also have some minimally invasive catheter-based procedures called ablation procedures that are also used to achieve that. So getting patients out of atrial fib and keeping them out of atrial fib. Cardioversion is a quick way to get someone out of atrial fibrillation. It actually refers to electrical shock that we deliver on the heart. And what a cardioversion will do, if you think about it, it's like you're pressing the reset button on the electrical activity of the heart. So for a split second, when we deliver that electrical shock, all the electrical activity will stop, including that atrial fibrillation. And the normal pacemaker of the heart then wakes up and takes over the rhythm, and the patient goes back to normal. Now, unfortunately, this doesn't have a long-lasting effect, so it works very nicely for that instantaneous conversion. But the options to keep the heart from returning into atrial fibrillation have to be either a medication or an ablation procedure. And then together with all of that, we also want to work with you on controlling any contributing factors, especially the reversible ones. So we can't really do anything about aging or family history, but we can do a lot about the choices that you make in terms of being more active or eating more healthy or avoiding any triggers or alcohol, caffeine, and smoking that can also contribute to atrial fibrillation. This is something that we spent quite a bit of time on with our team at the University of Washington AFib Center. And we have a multidisciplinary approach where we actually talk to a lot of our colleagues in the diabetes clinic or the weight management clinic, or we work with our partners on the primary care side of things to take care of all of the contributing factors, like reducing stress and avoiding smoking and alcohol and all of those things. So it is a multidisciplinary approach that will work. And our team at the university, and I'll tell you where you can meet with one of our experts later in the talk. We emphasize this multidisciplinary approach where we partner with the patient and their other providers to set goals and work towards those goals that would help us actually achieve a better result in managing their atrial fibrillation. So I have a list here of the different medications that are used to suppress atrial fibrillation. This is just information only, and just a couple of words about them, that they're usually prescribed under the direction of a cardiologist, and most commonly actually not just a cardiologist, but a arrhythmia specialist or a cardiac electrophysiologist. And these drugs have to be monitored, and a lot of times they can have side effects, and just like with anything else that I've shown you already, it's always a balance of efficacy and what we're using the drugs for versus any possible side effects and using them safely. So that's why they're drugs that are used successfully in a lot of patients, but carefully at the same time, so that we are not exposing the patients to any unnecessary risk or creating a new problem that may be a side effect from the drug. Now, a quick explanation also of what catheter ablation is and how does that work. So catheter ablation means that we have to use catheters to go to the heart and use different types of energy, either heating or freezing, to target certain areas within the atrium or the atria to treat the causes that are triggering the atrial fibrillation. So if we go through the images here, on the top left, you can see that the point of entry is going to be in a vein, and that vein is usually in the groin area. And once we get access into that vein, then we can go backwards through the vein all the way back to the heart. And most commonly, we have to work in the left atrium. So when we go backwards into the heart from the groin, we end up on the right atrium. So to go from the right side of the heart to the left, we have special equipment, and the people who do this are highly trained and skilled in actually puncturing that barrier that separates the right from the left. So we create a tiny hole that allows our catheters to get across from right to left and do the work that we need to do on the left side of the heart. So you can see the catheters here on the bottom left that have crossed over, and now they're positioned in the left atrium. And then sometimes we actually have to do it 2 times to have more than one catheter across. And now we're zooming in on one of these pulmonary veins. So you can see these 2 catheters in the vein, which is this kind of tubular structure here. So one catheter is used to record the electrical signals here, which is that circular type catheter. And then the other one is the one that's delivering the ablation treatment. Now, by comparison, if we look at the efficacy of these 2 different options as far as suppressing the atrial fibrillation, This has been studied in many clinical trials. The one I'm showing here, and I show it because it's one of the largest ones, and this is also a trial that was sponsored by the National Institutes of Health. So that means the NIH, the government, sponsored it, and there's no bias from any industry or any company that wants to sell its ablation catheters. But the message has been the same, that if you look at the yellow line here, which corresponds to the patients that got catheter ablation, and if you look at the dark blue line, which is patients who received antiarrhythmic drug therapy, the freedom from atrial fibrillation recurrence was significantly better in those patients who actually got treated with ablation compared to those who got treated with medications. So in terms of efficacy in treating the arrhythmia, ablation gives you a much better chance. But it doesn't mean that ablation is for everybody. It's just comparatively, it does a lot better than using these antiarrhythmic drugs. I'm looking at the chat right now, and I see that we have a question about pacemakers, and then what needs to be done if you have also aortic stenosis and valve disease. So I will get to that in a little bit. I have a couple of slides on that. Now, I also have to mention that when we talk about catheter ablation, I mentioned the heating and the freezing. So this is a picture illustrating the heating approach, similar to what I showed you before. 2 catheters going across that barrier into the left atrium, and then the catheter that actually is delivering the ablation here is the smaller of the 2. And as you can see, when we run a special kind of electricity through it, that heats the tip. So when the tip is in touch with the tissue, that tissue is also heated and therefore ablated. So that's the radiofrequency ablation approach. The other one is freezing, and this is called cryoballoon ablation. And that too also requires, the catheter to get across the septum over to the left atrium. So another puncture here. But the way this works is once the catheter is across, we can inflate a balloon, and that balloon is then advanced to the area that we want to freeze. And once we run our very cold nitrogen gas through that balloon, it drops its temperature significantly. So the tissue that it's making contact with is frozen as opposed to the heating. And then once we are done delivering that therapy, we deflate the balloon, and that's what allows us to pull it back out without any incident. So different techniques, but if you're curious about the efficacy in comparison with the radiofrequency, they actually are very comparable. So there's actually been several studies where the degree of AF suppression was compared between radiofrequency and cryoablation, and it was found to be almost the same. There are other technologies and techniques that are coming in the future here, and we don't need to go into all of them, but some of them involve using laser or different mapping techniques and different ways to deliver that ablation therapy. So we will be bringing those along and offering them to our patients as they become available. Some of them are actually available as part of clinical trials that we're participating in, and more of them will become more mainstay as we go forward. Now, I mentioned earlier also that ablation doesn't work for everybody. So there are some patients where ablation works better than others. And this is something that we do at the University of Washington, and that sort of sets our program apart from others, both in the region and in the country, because we study the atrium even before we ablate it. So we try to understand what are we up against with that atrium. We also want to know what it looks like anatomically. So patients who come to our center are evaluated with this MRI scan. And that MRI is a non-invasive scan. So we are able to study the atrium and the heart even before we put any catheters in the body. So we use that information that comes from the MRI scan to look at the anatomical shape of that atrium, but also look at how much scar tissue it has in it. Scar tissue that's built up from all of these factors like aging and wear and tear and other cardiovascular problems. But we also have shown that patients with diseased atria, or those that have a high amount of scar tissue, as you can see here from this staging system that we use, we demonstrated that those patients with a lot of scar tissue that you see here on the green, those patients don't respond very well to ablation. So those patients, for example, that are stage 4 that have had ablation have a success rate of about 31% in comparison to patients that are in stage 1, which have very little fibrosis, where the success rate is closer to 85–90%. So that's an important piece of information when we are talking to patients about different treatment options and which one fits best with their long-term options in terms of controlling their arrhythmia. We want to have that information handy, and it's something that helps us set our goals right and our expectations in the right place.
And Dr. Akoum, can ablation be repeated if AFib recurs years later?
Yes. So some of our patients who have had ablation and do well for a while, and then they start having AFib again, can have the option of coming back in for more ablation. Sometimes areas that we target with our ablation recover. So instead of turning into scar tissue, they actually heal and allow the electrical signals to conduct again. So they need to be ablated again or touched up. So sometimes we have to go in again and do that touch up or target any additional areas that may be problem areas that could have developed in the interim. So what is ablation actually doing to address AFib? Another question from the chat. The idea here is to make the atrium more resistant to fibrillating. So when we do it with the medication is chemically trying to do that. So it changes the electrical properties of the tissue that makes it more resistant to fibrillating. Whereas when we do it with ablation, we are also shooting for the same goal. We're trying to make the atrium more resistant to fibrillating, but we do it by creating barriers inside of the atrium for the electrical signals that propagate. So our ablation is strategically creating scar tissue in those areas that are triggering the episodes, so that when they try to trigger again, they run up against these barriers. So that means they will not be able to propagate beyond the barrier and cause the fibrillation to occur. So that's what ablation is trying to do to suppress the AFib. So in summary, comparing these two options, ablation as a treatment option to suppress AFib is much more effective than antiarrhythmic drugs. It's been shown time and again to improve that quality of life, reduce patient hospitalizations for atrial fibrillation. It's very safe in the right hands, and that means if you get it done at experienced centers that do it on many patients and with operators that are very skilled and experienced, like our team here at the UW, then it's a safe procedure. Any cardiac procedure does have some risk attached to it. Some things can happen, but overall, the level of risk with ablations for atrial fibrillation is maybe in the 3 to 4% range. And I know it's not zero, but it's also not terribly high. And then for some populations, like those who have atrial fibrillation and heart failure, ablating the atrial fibrillation can actually also help improve lifespan or longevity. And there's also a hint that also treating the atrial fibrillation, especially with ablation and getting rid of it successfully, also helps mitigate some of the stroke risk that we worry about. But I say that very, very cautiously because it has implications as far as stopping or continuing blood thinners. And this is a conversation that is very individualized, and I don't want to make general statements about that. It's something that we have to talk about with every single patient depending on their risk profile. Now I get to the pacemaker part. There are a couple of scenarios where a pacemaker may be needed with atrial fibrillation. One is a scenario that you see here on the left-hand side, where you can see that this patient is in atrial fibrillation because you can see that those spikes are fast and irregular and very chaotic. And sometimes we see this where you go from this fast and irregular rhythm and all of a sudden it's a pause and you have nothing for a few seconds, and then the heart has a beat. So the longer this pause, the more worried we get and the more symptoms are likely to happen. So symptoms that could happen with this are people might feel dizzy with this pause. They might even pass out or lose consciousness. And a lot of times if they're on medications to treat atrial fibrillation, then those medications will also make these pauses even longer. So this is a scenario where a pacemaker may be needed. And what a pacemaker will do is it will be monitoring the heart rhythm. If the heart's going fast on its own, the pacemaker will not do anything. It'll just continue to watch it. But once it sees that the heart is slowing down, once it reaches a certain level, then the pacemaker will kick in. So the pacemaker is programmed to intervene when the heart tries to go slow, and it prevents it from going slow, and it keeps it at a minimum. That's usually something that's programmable and something that your doctor will set, what your electrophysiologist will set in the office. The other scenario where a pacemaker might be considered in patients with atrial fibrillation is kind of a option of last resort when we have tried everything we could to treat the AFib and we fail. So we've tried medications and we've tried ablations and we've tried cardioversions, but the AFib keeps coming back, and it's just hard to control the heart rate when you have AFib and it's just always racing despite all of these medications. Then that's another scenario where a pacemaker might be considered, where it's not just a pacemaker, it's a pacemaker in addition to a very limited ablation that targets a special relay point in the heart called the AV node. So the AV node is the relay point between the upper chambers where it's fibrillating and the bottom chambers that do the squeezing. And if we interrupt that connection with ablation, then those upper chambers will continue to fibrillate as much as they want, but the bottom chambers will not race anymore. In fact, quite the opposite. Once we sever that connection, once we ablate that relay point, then the bottom chambers will actually go very slow. And this is why a pacemaker is needed. And it's to support the heart rate and bring it up to normal range again. So it's not a fix for the AFib. It's just a treatment of last resort when we are going to live with AFib, but we don't want to worry about the rapid beating that comes with it. So it's something that we offer to patients who are at this stage where we've tried everything and we are going to live with the AFib, but we want to limit how fast the heart's going. So we combine a pacemaker and an ablation for this AV node to give them more heart rate control, but they will continue to be in AFib. So that's the pacemaker scenario. Another question here from Randy, is ablation always successful? No. So some patients respond to it, and sort of the all-comer success is maybe in the 60 to 70% range. That means about 30 to 40% of patients will have recurrence of atrial fibrillation after, which means that we have to either ablate more or combine ablation with antiarrhythmic drugs, or basically decide with the patient what's the best course of action depending on how much AFib they're having and what are we shooting for. So if we're trying to have as little episodes as possible, that may be achieved with several ablations or ablation in combination with drugs versus trying to eliminate the AFib altogether. All right. Is there a risk of an ablation procedure damaging other organs? The short answer is no. And there's no evidence that ablating for atrial fibrillation does any damage on the heart function or any other organ's function. If anything, bringing the heart from atrial fibrillation back to normal rhythm is good for other organs, like the kidneys, for example. They do better when the heart is pumping in a normal, regular fashion. Now, sometimes, despite your best efforts, you might run into some procedural complications, and that sometimes can have some organ damage, but this is very, very uncommon. Does having a pacemaker mean your heart rate is now fixed instead of variable? That's a great question. So pacemakers have a feature that's built into them that will allow them to sense when your body is exercising or moving. And we turn that feature on when we have to go to the pacemaker option in our AFib patients, so that when they're at rest, they're at that lower number, which is usually 60, 70 beats per minute. But once they get up and their body's in motion, the pacemaker will sense that, and it will pace them at a higher rate, trying to catch up with the level of activity that they're doing. So all of these are programmable features in a pacemaker that will overcome that limitation of being paced, and it will be adaptive to the level of activity. Janet asks, how often is the esophagus affected? Luckily, not very often. So the esophagus is important because the esophagus's course in the chest is right behind the heart and right behind the left atrium specifically. So that means when we ablate on the atrium, we're always mindful that we don't want our heating or freezing on the cardiac tissue to traverse across those layers and get to the esophagus. So the worst case scenario is an esophageal injury that can lead to severe damage on the heart and the esophagus, and a communication between the two that's called the fistula. And the incidence of fistulas is probably less than 5 in 1,000. And we are very careful about the esophagus. We monitor the luminal temperature as we're doing our ablations to try and pick up any major temperature changes. Sometimes we also evaluate the esophagus right after the ablation, the day after, with a endoscopy test to make sure that there isn't any sign of a thermal injury on it, so that we are on top of any potential damage on the esophagus, and we know about it and we can treat it before it progresses to this bad scenario called atrial esophageal fistula. All right, is the Watchman an option for AFib? So absolutely, it's an option for dealing with the stroke risk that's associated with atrial fibrillation. So think of it as an alternative to the blood thinners that we have to consider with managing the stroke risk. So for those patients who are also at risk of bleeding and they can't tolerate a blood thinner, or they prefer not to take a blood thinner, then the Watchman is one of those appendage occlusion options that we have that can be an alternative to taking the blood thinner. So it will help us mitigate the stroke risk. Unfortunately, it won't help fix the AFib. So the arrhythmia, the electrical abnormality will still be there, but the stroke risk will be managed by the Watchman. So the Watchman will take care of the stroke risk, but we still have to look at our other options, medications or ablation, to fix the rhythm part. Anne is asking if a patient has a high CHADS-VASc score, is on warfarin, and has a subdural hemorrhage, and all blood thinners are stopped and is not a surgical candidate, what are their options for protection against stroke? So this is exactly the scenario that we're thinking about, this balance where on the one hand, you want to protect them against stroke and you try to do it with a blood thinner like warfarin in this case, but the alternative that you're balancing against is the bleeding. And unfortunately for this scenario, it did happen where they did bleed. So, so you have to consider that appendage occlusion option very strongly in this case. So the appendage occlusion option with Watchman or the new occluder called Amplatzer or Amulet are very suited for this type of scenario where they will offer the protection against strokes, but without having to use the blood thinner on the long term, and therefore you're mitigating the risk of bleeding by avoiding the use of the blood thinner. How does a person determine if they are a candidate for ablation? This is a conversation that you have to have with your electrophysiologist. So you have to start with your AFib symptoms and their impact on your quality of life. We also need to look at your overall heart health and see what kind of shape the heart's contractility is in, and whether restoring the normal rhythm to the heart is beneficial there or not. And you also have to talk to your doctor about the procedure itself. What are the likely outcomes? Are you likely to get a positive response and suppress the AFib? You may get an MRI and see how much scar tissue there is on your atrium and try to be as personal as possible in estimating that success chance. And together you make that decision whether to go ahead and have an ablation or not, and with the goal of improving the quality of life primarily, but also improving heart's function and everything positive that comes with that. Let's see, another question in the Q&A. If on blood thinners, how does one know how well they are working to reduce the stroke risk prior to considering the LAA occlusion procedure? So if you are on warfarin or Coumadin, the way to tell how well they're working is by having these periodic checks of the INR level. We don't go in and look for blood clots just to screen and do surveillance to see if the blood thinner is preventing them or not. If you happen to be on one of the newer agents, the Pradaxas or the Xareltos or the Eliquis or Saveza, then you only need a blood test before you start your treatment to make sure that you don't have any bleeding disorder or poor kidney function or a contraindication to be on the medicine. But once you start these newer agents, you don't typically have any blood work to monitor the level of blood thinning. You just have routine labs drawn every year just to make sure that your kidneys are still good and you're safe to continue with that drug. If on the other hand, while you're taking that blood thinner, you do develop an embolus, so a stroke, God forbid, or some other blood clot go into a different organ, then that's extremely unlikely. But if it happens, it kind of starts questioning the efficacy of the blood thinner that you're getting with that particular agent. And a lot of times we have to investigate further and see why it happened and whether it's a bleeding, sort of clotting disorder, or whether you need a different agent. But this scenario is very unlikely. And then, considering the left atrial appendage occluder, Anne asked about that bleeding scenario, but some people are worried enough about being on a blood thinner because of sort of imbalance problem or frequent falls or frailty in general, or maybe lifestyle if they are, downhill skiers or, they go out biking or something and they're just concerned about being on the blood thinner. A lot of people consider that appendage occlusion option as an alternative to being on the blood thinner long term. Okay, what needs to be done if you have aortic stenosis and valvular heart disease? So that's a great question. So a lot of times when you have valvular heart disease together with your atrial fibrillation, and you have to think about treating those valve conditions and seeing if there's an opportunity to treat the AFib at the same time, especially if you're going for surgery. So if you're going in for an open heart surgery to replace a valve or repair a valve, and you have atrial fibrillation, then there's usually a conversation that happens between your electrophysiologist and your surgeon about trying to do an ablation at the same time as the valve surgery. So the surgeons can also do ablation when they have the chest open and the heart exposed. And sometimes the electrophysiologists participate in that as well. But you can have a surgical ablation. This is not the same one that's done with catheters that I showed you. This is one that the surgeon can do with different tools, but with the chest open. So this is something that you need to consider if you happen to have both diagnoses. If you are not going for open heart surgery for the valve disease and you're going to have one of the percutaneously delivered valves, then we treat that first and see if fixing the valve problem helps reduce the AFib burden or solve the AFib problem. So I would go for the valve first, and then if AFib remains a problem after one of these percutaneous valve replacements, then again, going back to the electrophysiologist and having a conversation about ablation or drugs to treat the AFib. All right. I don't see any new questions in the queue. I was just gonna finish with, when should I see an AFib specialist? And I would say anytime. It's never too late to talk to a specialist about this. In general, our therapies, especially ablation therapies, actually work better if we have these conversations with the patient early in their disease process. So our outcomes are better when the AFib is still in the paroxysmal phase, when it's not been too long of a time from diagnosis to when you actually meet with us. So we get better results if we intervene on it early, and especially if we engage with the primary care providers and other specialists to tackle all of the contributing factors and make the lifestyle changes that are necessary to get to the result that we want. Our AFib clinics are available at across campus. So our main clinic is at University Hospital in Montlake, so the main UW campus. But we also have providers, cardiac electrophysiologists that can provide AFib care and consultation at Harborview Medical Center, at our Northwest Hospital campus. And also we have electrophysiologists at the Puget Sound VA or Seattle VA that are experts and actually can give excellent advice on managing AFib. All right, one more question here. If paroxysmal AFib occurs after ablation and medication isn't a large concern, yeah, I mean, it again goes back to how symptomatic that person is. So if the AFib is causing a lot of symptoms, even if it's happening after ablation and medications, then it needs to be dealt with. And all of the options are on the table. Even if you've had a previous ablation or failed a previous medication, you can try a different medicine, or you can try another ablation to get more suppression and hopefully complete suppression, and therefore fixing the problem and giving that person better quality of life. So it's not a concern if you've had previous treatments. Your options are still all available to you. All right. Let's see, any other questions, comments?
Yeah, thank you so much, Dr. Akoum. It's fantastic. Everybody, when you do log off, there will be a survey. If you can fill that out, it will be anonymous, but that would be very helpful to help with more content like this. It is Heart Health Month. There's more on our calendar. Keep in touch on Facebook, as well as our YouTube page. We'll have more of this content available throughout the month. But I'd like to, again, thank you, Dr. Akoum. It was a really great presentation.
Thank you for your attention. Thanks for the opportunity to chat today.
All right. Thank you, everybody. Have a good week.